Welcome, everyone. It's a delight to open this webinar formally on the EAGLE trial, which has been published last week in the British Journal of Surgery, thanks to the collective efforts of thousands of surgeons across the world. I'd just like to say it's been a privilege to work with you over the last 2 years. At this webinar, we are going to talk about the design of the study, the results, and we are going to introduce EAGLE-2. And to open the program, it's my pleasure to welcome the senior editor at the British Journal of Surgery, Des Winter, who has been collaborating with us on delivering this publication. Thank you, Des.
Hi, everyone. Welcome to this webinar. And what an exciting time it is for the BJS to be partnering with you on these really, really exciting studies. The EAGLE has indeed landed, as Dion said. We have published it recently. And I think this isn't just the paper of the year. I think this could easily be the paper of the decade for me, definitely, and probably is the most exciting thing that's come through our journal, I think, in the last 25 years. I say that, I don't think that say that lightly, because there are very few papers that are actually as impactful as this, that actually make a difference in terms of what it is that you all actually did previously. But far more exciting is, how do we disseminate this and how do we get that message out there that you actually can transform patient outcomes for safer surgery through simple, easy digital intervention, digital education. And that, of course, is what BJS is all about. As many of you know, we've gone from being a paper journal to now being a fully online concept. And indeed, precisely with this type of concept in mind, we have projected ourselves far beyond the simple digital into the BJS Academy, which is a free-to-access platform for education all over the world, provided, of course, that there is that digital access. And that really is now the only thing that separates something as marvelous as EAGLE from being disseminated around the world, is simply digital access. And of course, perhaps linguistics. And linguistics, of course, you as a team have done a fantastic job in actually making sure that that is available in as many languages as possible at this time. So what a fantastic effort from all of you. I mean, as an editor, it's an absolute pleasure to get a paper like this. It doesn't require an awful lot of editing. It doesn't require an awful lot of correction, because there's very little wrong with it from the onset. The only thing, of course, that we changed ever so slightly was the projection of the abstract, because I thought that the most important message to get out there to the world was, if you complete the digital online educational program, your team, your hospital will see a reduction in anastomotic leaks for right colectomy in your patients. And that to me is a huge, huge thing to see. I mean, very, very little has done that in surgery. If you think about the surgical risk over time, what halved risk, you could say, radiotherapy did, perhaps in breast cancer. More recently than that was also rectal cancer and perhaps an esophageal cancer. But there are very few interventions that we can do as surgeons which make immediate differences like this to patients. And an anastomotic leak, to drop it from roughly 10 to 12% to down around 5%, that is an enormous change. We speak always in terms of percentages as surgeons, don't we? We as doctors too, and we think of things per 100. But I mean, per individual patient, my goodness, that is an enormous difference. If you were that patient, having an anastomotic leak or not is a massive difference to you, both in terms of your quality of life, in terms of your risk to life, in terms of your length of time in hospital, your ability to return to work, your ability to be back inside the family normal social structures. And for some people in some parts of the world, this could be life-threatening or life-ending. So BJS has been around for over 100 years. Roughly, we've just turned our 110th anniversary approximately. We are partners in terms of society partners with multiple people from various parts of the world who are learned educational societies. This is perhaps one of the first times that we've really stepped up to engage with a group from a global capacity who are interested in this type of transformative digital education. And I think it's an ideal partnership with us for that sort of mutualistic, safer surgery goal that we all are interested in. I must say, if you had said to me 2 or 3 years ago, we plan to have over 60 countries involved with over 300 teams, with over 3,000 patients, and we look to have the leak rate in those completing the program, I would have said that is probably too big a task. Well, you did it, and my absolute congratulations to all of you for doing so. And thank you for trusting the BJS with your work. I promise you that is valued. I promise you we'll do our best to get that message out there and through all of the various capacities and channels that we have. With further ado, none, I will pass you back to Dion Morton with my hearty congratulations again. Thank you.
Thank you, Des, for those kind words. I'm sure they're really appreciated by the wider Eagle research community who have worked so hard during the pandemic to deliver this trial. Now, look, we don't want to just look backwards, we want to look forwards. We want to see a transformation in care for our patients. Des outlined it beautifully. We want to see a massive reduction in anastomotic leak rates. So we are going to launch Eagle 2 from this platform, and we'll be looking for as many surgeons across the world as possible to undertake the Eagle Education Training Platform, which is now free to access, open access to any surgeon, anyone who wants to use it. We'll talk about that later. So let's talk about the study. We're going to have 2 short presentations, one to celebrate the design of the Eagle trial, and then to look at the results. So I'm going to hand over to James Keatley, who is the manager in charge of this trial and well known to all of you. James, tell us about the trial.
Hi, my name's James, and I am the project manager for the ESCP Safe Anastomosis Eagle study. And today I'm just going to be giving you a brief overview and background of the study. Just to recap, the aim of the study was to determine whether the ESCP Safe Anastomosis intervention led to a reduction in anastomotic leak following right hemicolectomy. And one of the key secondary aims of the study was to demonstrate the utility of a new methodology. This was the first time that the Eagle methodology had been used, and we're hoping to replicate and use this methodology again for future studies. In terms of the trial design, sites were randomized to one of 3 randomization sequences. Sequence 1 received the intervention first. They had 1 month to complete, and then they collected post-intervention data for 2 months. Those that were randomized to sequence 2 had 2 months of pre-intervention data collection. They then received their intervention before collecting post-intervention data for 2 months. And those that were randomized to sequence 3 collected pre-intervention data only for 2 months, and they received access to the intervention at the end. In terms of delivery of the study itself, this is how we delivered it. You can see that various ESCP research committees supported the study. We had a study management group, and we had an operations committee that met weekly to oversee the delivery of the study, to look at what issues there were and to undertake any actions that had to be undertaken. But key to the delivery was the role of the meta coordinators and the coordinators. They were responsible for setting up the study across the globe. They helped with approvals, they troubleshooted any issues, and they made sure the study was being delivered correctly in hospitals around the world. They also promoted the study, and without their input, Eagle simply wouldn't have happened. And one of the really exciting things about the study was the development and the establishment of new networks. We had a fantastic network that was set up in South America, and that was led by my colleague Nicholas, who's going to be on the panel today, and he's going to be sharing his experiences. We had many hospitals from across South America from Brazil, from Argentina, from Mexico, from many other countries that were taking part in ESCP studies for the first time. So that was really exciting to see. We had a fantastic network led by the GSU India Hub. We had lots of participation from hospitals across India. And we also had new networks that were set up in the Middle East and North Africa, in Nigeria, and in Southeast Asia. In terms of the scale of the study itself, you can see that EAGLE was active in 64 countries, and that was in high, middle, and low-income countries across the world. In total, we randomized 355 hospitals to take part, and they were randomized across 16 different randomization sequences, and more than 3,000 patients were included in the final analysis, which you'll hear more about in the next presentation. In terms of the intervention itself, the exciting news is that this is now free to access. You can scan the barcode, the QR code, and that's going to take you straight to the EAGLE educational platform. Now that the study has finished, we really hope that as many surgeons from across the world can undertake the intervention, undertake the EAGLE training, and you can access that at your leisure. And we'd be delighted to hear any of your feedback on the educational platform. In terms of this study, we issued more than 4,000 logins to surgeons around the world, and more than 2,000 surgeons completed the online educational training, and they were issued CPD points. And you can see just a few examples. We had 24 surgeons from New Zealand who undertook the training, 40 surgeons from Syria. We had 300 surgeons from Spain who undertook the training, and we had 59 from Brazil. So again, it just shows the global reach of the EAGLE study. Again, please scan the QR code, access the platform, and it will take you directly to the website and you can undertake the online training. And lastly, these are just some of the people who took part in this study, some of the people who helped deliver the study, and some of the people who made the study a success. Thank you to all of the investigators from around the world who took part. Thank you to all of the surgical teams who took part in the study, and we look forward to working with you again in future studies. Thank you.
Thank you, James. That was absolutely fantastic to think back those many happy memories. I'm sure all of you have many happy memories from running the EAGLE study. But actually now we're going to move straight into the results. I'm delighted to introduce Elizabeth Lee, who actually was the lead author on the paper in the British Journal of Surgery. So Lizzie, the results of the EAGLE study, please. Thank you very much.
Hello, my name is Elizabeth Lee. I'm one of the surgical registrars and academic clinical lecturers from Birmingham in the UK. I have the pleasure and honour of presenting the results from the EAGLE randomised control trial. Firstly, to describe the population that were recruited to this study. The operated patients were quite comorbid. 1 in 5 were obese with a BMI of over 30. 1 in 5 had diabetes. 1 in 5 had ischemic heart disease or a cerebral vascular accident, such as a stroke or transient ischemic attack. And a third of these patients were smokers or had a smoking history. We also found that 14% of all the operated cases were contaminated or dirty surgery. A quarter of all of the cases were emergencies. Just under half of all patients were ASA 3 to 5, and the primary operation surgeon was a colorectal consultant in only just over half of all the cases. So for the final primary results, what we found was that there was an absolute reduction in anastomotic leak. However, this did not reach the pre-specified significance level that we had determined and aimed for before the start of the study. And overall, the odds ratio of the intervention in preventing in preventing anastomotic leaks was 0.88 and the p-value of 0.231. However, when we drilled down into the data and looked at engagement with the online learning platform and also implementation of the recommended interventions, as well as the outcomes at the patient level, we found something interesting. We found that depending on the level of engagement of each hospital team, this directly correlated to the implementation of the recommended interventions and also to the outcomes at a patient level. For example, those hospitals where the team were engaged with the online modules of 50% or less, they had the lowest level of implementation of all the 3 different interventions, and they always also had the highest level of anastomotic leak. And this pattern was correlated across our study. And we were able to demonstrate that this was translated from engagement to implementation to leak. We also found that we're comparing pre and post intervention, that this was a significant reduction in anastomotic leak in those with high engagement. So in conclusion, what we found is that this is the first generation implementing behavioral change in surgery. The effect was greatest when the intervention was actually applied and there was very good engagement. And though there was no overall conclusive evidence of reduction in leak, there was in subgroup analysis, especially in those hospital teams that applied the intervention. Thank you very much.
Excellent, Lizzie. Thank you so much for that brilliant summary. I really enjoyed that. And I think it's worth emphasizing that subgroup analysis of uptake of the intervention was actually a pre-specified secondary analysis. It wasn't exploratory, it was pre-specified. So we had some really exciting experiences there. So I'm delighted to introduce the panel. I'm going to start with Miguel Cunha from Portugal. Miguel was leading the program in Portugal. So Miguel, what was it like to run Eagle in Portugal? Did you enjoy it? Would you do it again?
Thank you very much, Professor. I enjoyed a lot, and I think that was the global sensation from the Portuguese surgeons. We had a global interest in this specific study. Mostly, I believe, because of the methodology, the new methodology of the study, the education model.
And introducing Gaetano Gallo from Italy. Gaetano, you also led the Italian vanguard, and there was a great interest in Italy in this study. What was it like to provide that leadership? How did you engage your colleagues?
Thanks very much for this question. It was exciting and engaging, although we were severely affected by the COVID-19 pandemic, which delayed partially the completion of the study. But it was a nice and long journey, especially for the teamwork carried out, thanks to James and the whole team. As you know, with Francesco Pata, we had already built a good collaborative network, and all Italian colleagues were also enthusiastic about participating in this quality improvement intervention, requiring a multidisciplinary team of surgeons, nurses, anesthesiologists to implement practice change within a hospital. And in fact, we gave the possibility of consolidating relationship also between different specialties, and that it was important.
So if I could push you, Gaetano, would you be able to persuade more colleagues to undertake the educational program? Could you recommend it to them?
Of course, I will, and I'm sure that more and more surgeons from Italy and from all Europe will, they will be really pleased to participate in the new project, in the Eagle 2 project that you will launch now.
So we will need to encourage surgeons across the world to undertake the educational platform so we can repeat the Eagle assessment and see if we can substantially reduce anastomotic leak rates. Miguel, is this something that colleagues in Portugal might participate in?
Of course, the interest in the first study, the Eagle 1, was big, but I think it will be even bigger when we see the results of the paper. This is a really teamwork. And as we see that as much surgeons inside the team do the education model and the results are better, I think that seeing these results will motivate all the surgeons to do this education model.
Yeah, I think that we're going to use this phrase again, aren't we? Teamwork is so important. It took teamwork to run the study. It takes teamwork to actually look after our patients. And maybe that's one of the big lessons for us as surgeons, something we need to take away and think about. So moving to a non-surgeon, James. James, really fantastic working with you and running the study. So was this reproducible? The management of the study was enormous. It was a huge undertaking. Could you see this being reproduced and done again?
Yes, absolutely. It's a proven approach that we use for Eagle, but we've also used it for other studies too. So some of the COVID surge studies that people would have been involved with use similar management structures, and they were delivered with huge success. And we've got the networks, we've got the expertise, and it's a methodology, and it's going to be a structure with support from the likes of Gaetano, from Miguel, from other national leads that we can use to deliver studies rapidly across the globe.
So James, at the end of this webinar, we're going to invite national leads to join to drive Eagle 2. Can I ask you, James, are you prepared to work with me again? Could you bear it?
Do I have to answer that one now?
Okay,
Absolutely.
We'll take that offline. No, you're quite right. Look, Lizzie, can I come to you now? Great presentation and results. I mean, lots of results, lots of data, lots of lessons. But for you, what was the most important finding? What did you take away from this?
I think, as stated already, it really is about the teamwork. What this study touched upon, which was not directly measured, was what it meant when everybody had agreed on patient treatment. So, and that everybody were on the same side and aligned in what they wanted to do clinically. So a bit like the WHO checklist before you start operating, it feels like lining up the troops before you go into battle, and everybody has a sense of cohesiveness and togetherness as well. So perhaps that has added to the success of Eagle on that front. And it's something as surgeons, when we are very used to individual practice and our own practice, it's something perhaps that we've never thought about much. But this is a great opportunity to move into this territory and engage with your team.
Yeah, it's the teamwork that gives the pleasure of running the studies, and it's the teamwork that drives the success of the studies. And actually, it's the teamwork that benefits the patients. It's an interesting synergy. I don't think I'd fully appreciated it before Eagle. I think Eagle really drove that home to me. So staying with the teamwork theme, going back to Miguel in Portugal. Miguel, how were you able to build effective teams across your participating hospitals in Portugal?
It was more easy than I thought. In the beginning, I thought that it is a multidisciplinary team from different specialities, including the nurses, and I thought it would be difficult, but no. With all the intervention and with the main aim to reduce the anastomotic leak, what we saw was that everyone wanted to participate in the study to improve the results. That was a good thing to see in the Portuguese centers.
Yeah, when I look at practice across the world, it's interesting. Even if you look at our own practice, you see multidisciplinary teams in cancer, for example, that work very well together, that are very effective. And you see others that aren't quite so effective because they're not working quite so closely together. So there is something we can learn from this. What about in Italy, Gaetano? In Italy, was it easy to build teams? Were you able to bring people together around Eagle?
At the very beginning, it was really easy because we were in the pre-pandemic period, and afterwards something changed. I used to work at that time in a referral center, so high volume colorectal cancer center, but we built a team, and in our case, even if I worked in this referral center, the intervention led to an important decrease, even if not p-value satisfying, an important decrease in the leak rate. So it's not everything about p-value in this case. P-value can change with change in the volume of patient involved. So for me, it's also important to consolidate relationship with the nurses, for example, that are also very enthusiastic to participate in the study. And most of all, the standardization of everything, of this process, is really important.
Yes, it's when we talk about harmonizing practice, I think that people understand that. We're trying to simplify the processes and make them work. I really like some of the analogies you've alluded to there. And I hope that we can carry this forward into Eagle 2. So before I close this first panel, Lizzie, the teamwork was an incredibly important finding in the study. Were there any other take-home messages that you think might be worth sharing with our audience today? And of course, those who listen to it afterwards, recorded.
I think it's more so to not underestimate the power of being able to offer multiple different interventions that will lead to behavioral change, and not to shy away from complicated interventions. As surgeons, again, we prefer, for example, a stapler versus this particular stapler, but sometimes it takes marginal gains throughout many steps to get to a good result. And that's what we are looking to be able to produce in the future.
Right. I think that's a very important point that we should just emphasize there, that we're at the beginning of a journey. We want to minimize and we want to stop all avoidable anastomotic leaks. That's transformational for our patients. That's not a one-off process. That is a journey. We're at the beginning of a journey. It's a long flight for Eagle. It's going to be a long journey, but it's one that's very worthwhile undertaking. I think there were one or two other things in the study, Lizzie, I would just highlight. I think that the fact that it was the clean contaminated wounds, the abdominal cavities that actually had the biggest benefit. There was a subgroup of kind of intermediate risk patients where we could really make a big difference. And I think there's some lessons for us there as well. So I'd just like to thank the panel. I'll close this first panel. And we want to now open the educational platform for all surgeons across the world to access. So it is now open access. There is no code required. There is no charge. Anyone can access it from anywhere in the world, and anyone can complete the training modules. We want as many surgeons as possible to do this so that we can then measure the impact on anastomotic leaks across the world. So I'm now going to hand over to James Glasby, another one of the senior team of the Eagle Collaborative. And James is going to talk to us about the educational platform and its components. James, over to you.
Hi, my name is James Glasby, and I'm a general surgery registrar in the West Midlands in the UK, and I'm part of the Eagle core team, particularly involved in designing and developing the educational modules that were part of the EAGLE intervention. I'm delighted to talk to you for 5 minutes today a bit about what this platform had to offer and the different components of the EAGLE intervention, as well as how you can now access it in the wake of publication of the trial results. Just to start by saying huge congratulations again to all of the EAGLE collaborators. This was a truly phenomenal global effort, and it wouldn't have been possible without each and every one of the collaborators. So thank you all, and I look forward to seeing this getting implemented in practice around the world in the future. So there was 3 components of the EAGLE intervention. The first was routine risk stratification for patients undergoing a right-sided colectomy with anastomosis. And that was trying to provide a numerical risk percentage, which could help guide your conversations in clinic with patients, as well as your intraoperative decision-making. The second point was, can we involve other members of the multidisciplinary team, so anaesthetists, theatre staff, anyone else that's present at the time of the anastomosis, in that decision about whether we should proceed or not, and if we are to proceed, which technique should be most appropriate, and do we have all the correct kit available? And the final component of the EAGLE intervention was really about sharing best practice in anastomotic technique amongst the global community, and perhaps reducing some unwanted variation in more nuanced techniques for right colectomy. So this wasn't prescriptive saying this is the way that you should do a colectomy and anastomosis, but just providing the best available evidence for people to reflect on. So the way that the intervention was delivered was by an interactive online platform that included both kind of didactic lecture type content, but more excitingly, fireside chats, which were interactive discussions between different members of the global colorectal community, which also included trainees, operation videos, and links out to key pieces of evidence and webinars. It was a modular structure which allowed you to work through at your own pace, and it was designed to be accessible for any member of the surgical team delivering right colectomy, and there were individualized modules available for anaesthetists and for theatre staff too, so this wasn't just for surgeons. The 5 modules were around those 3 concepts, so the risk stratification, this ESCP safe anastomosis checklist to aid multidisciplinary communication, and the last 3 around this harmonizing technique concept, so preparing for your anastomosis, and then best practice in stapled and hand sewn. The modules are now available free to access for everyone outside of the trial. So any surgeon or anaesthetist interested in right colectomy around the world can now access this free of charge. It's available on the BGS Academy website. So a huge thank you to BGS for supporting this publication and open access to the modules, and also via the ESCP website. This is a little look at the platform. So you've got your 5 modules that you can click on at will, and there's an index which you can work through at your own pace, and you can tick off when you've completed them. And this was part of the fidelity monitoring in the trial, checking who'd completed which modules, how much time they'd spent on each one, and how that translated then to implementation of the techniques on the case report forms in the files. But now, of course, now the trial's been published, this is just for your own record to keep up to pace with where you've got to, and also use it as evidence of continuing professional development if that is useful to you. This is an example of some of the content that you might find. So this was a chat about risk stratification, working through some case studies and how the risk stratification may have influenced your decision whether or not to do an anastomosis or at least a conversation with patients. And for each module, you also have the opportunity to add reflections in the notes, which you can print off at the end of the module. This was our ESCP safe anastomosis checklist, which to me is one of the most exciting elements of EAGLE. And I've seen in my practice and that within the teams I'm working with, the concepts here have actually changed the way that we do anastomosis in many instances. So the first step was checking with your anaesthetist that they've not had any hemodynamic instability or unexpected blood transfusion during the trial, and just checking on how long you've been operating for, which we know is a independent risk factor associated with risk of an anastomotic leak, and then a discussion with the whole team about whether we still feel it's appropriate to proceed to anastomosis. And the really key thing here is that calculator actually adjusts the calculated risk if you have an unforeseen intraoperative complications. So if you have a big bleed or contamination or technical challenges for one reason or another, that will influence the risk of leak. So you can refresh that score and then discuss it again across your team. If you are planning to proceed to anastomosis, you can then talk about hand sewn or stapled, which one you'd like to do and what you need so that the team can get all of the kit ready and available. So this is our ESCP Safe Anastomosis Checklist, which was used in the thousands of patients in the trial, and we hope to continue being used across the ESCP network in the future. So this is a little overview of the ESCP Safe Anastomosis platform. We're now hoping for as many surgeons and trainees around the world to complete these 3 modules. We're hoping perhaps to work with the ESCP to bring it into their routine training, as well as other national and regional organizations. They do take about 2 hours to complete, but I promise you time well spent. And we can see in the evidence from the EAGLE trial that when we interact with this, engage our teams, it can really make a difference for patients. So thank you very much for listening. I'd be delighted to take any questions in the panel session.
Fantastic review of the educational platform. Now, this is so important to us because if we want people to engage in EAGLE 2, we have to get access to that platform. So can we bring in the second panel now, please? Welcome, everyone. Hi. Well, that was a great review of that, of the educational platform. It's lovely to see Professor Simon Ng from Hong Kong. Simon is the co-chair of the Global Reach Committee for ESCP. Simon, what was it like to get engagement across your Global Reach Committee from all those different countries across the world?
Well, thank you very much, Dion, and also thanks to James for the wonderful presentation. Now, currently in the Global Reach Committee, we have representatives from, I think, at least 10 colorectal societies across the world, mainly from Southeast Asia, and we do have new members from South America. Now, I think the EAGLE study, I think it's a very good learning process for the Global Reach Committee, because I think the Global Reach Committee is mainly for promoting global collaboration in research and education. And the EAGLE study is actually one of the very early attempt of the committee to participate in this kind of research. So now I think it's some of the members are more active than the others because I think it's a beginning. Like we have colleagues from Malaysia, and April is here. I think she can tell us more about, building a network within Malaysia. In Hong Kong, we're also actively participating, and also in Taiwan and Korea as well. All right, but I think it's we were really very excited to see about the publication, the end result of the whole study. And obviously, I think we're all looking forward to the EAGLE 2. And with that, I think the members within the Global Reach Committee would certainly like to disseminate this information to all the other members, hoping that more surgeons can join the educational platform in order to participate in the EAGLE 2 study.
Thank you, Simon. So we had great participation from the committee, but Juan, in Mexico, you had also the language problems. How did you find your colleagues engaging with the education platform? What could we do better? Any thoughts?
Well, based on the feedback received from my colleagues, the education platform was generally well received for its ease of use. The intuitive design and clear navigation tools facilitated a smooth user experience, allowing them to focus really on the educational content rather than the grappling with technical difficulties. However, like any system, we thought there was a learning curve involved, but it was not the case. Some colleagues encountered minor challenges, but these were quickly overcome because of the platform's comprehensive and support resources. It's important to note that the ease of use can be subjective and dependent on individual comfort with technology, but the majority found the platform user-friendly. So I believe there was no really language problem and no really something to really change a lot for now the launch of the EAGLE study.
Thank you, Juan. That's really encouraging. I still think we need to do more about language. One of the ideas we had from some Central European colleagues is they actually held kind of symposia where they showed the online training platform and they discussed bits they didn't understand or they explained them to each other. So maybe some kind of collective approach to the online training might be useful. I'm delighted to bring in April, who led the network in Malaysia. You led a fantastic network, April. We're so grateful. It's been such a pleasure to work with you. April, perhaps you could share with us, what did you find the challenges in engaging your colleagues with the educational platform? How did you persuade them to join us?
Thanks very much, Dion, and it's a pleasure to be part of this amazing work. In a way, having had the pandemic kind of delay the rolling out of Eagle was somewhat fortuitous in terms of easing our comfort level with using electronic platforms. So prior to the pandemic, we were still very much using conventional methods of teaching and learning and training. So the benefit, if you can say the pandemic brought us any benefits, was that everyone from trainers to trainees were actually quite comfortable with utilizing electronic resources for learning. And I have to say that because our training is delivered nationally and it is coordinated among all the training hospitals, primarily public hospitals, it was relatively easy to gather a network that was interested in this because it would lead to improvement in outcomes, or it was hoped that it would lead to improvement in outcomes. The other factor that made it easy to get buy-in is that we tend to have to release our surgeons to independent practice relatively early in their careers. So it was important that they also, although they were trained surgeons, it was important that if they were the sole surgeon in their hospital, they would have this resource like the risk calculator that would give them some comfort level or some confidence that they were making the right decisions. So I think it's been really an amazing experience. It has strengthened the relationship between the hospital, the trainers, the trainees. And what I'm hoping now is that since this is now open for general consumption, that we want to engage with our colleagues in the private sector and hope that they will also start using it in the hopes that it will lead to better outcomes for their patients.
Wow, great ideas there, April. Really love it. We're also talking to our trainers, and I know that you're a dean at the University of Malaya, and I think that we might be able to get the platform onto the educational training platform for the trainees. Is that something you might be able to do in Malaysia?
No, that's really what I was going to say next, because I really think that as we are moving towards standardizing the training throughout the country, the training resources also have to be accessible to all. So we've actually started with the trainers, interestingly enough, to get them all trained to the same curriculum, the same sort of modules. But I do think a resource like this would be something that we should integrate into the training materials for training programs. And
we're going to try and do that in the
really
UK
going to
as
be
well.
able to do that. Yes.
Yeah. Good luck. So I'm going to bring in Sophia here. Sophia's one of the leaders in Young ESCP. Sophia, do you think we could interest trainees in this platform? How could we ensure their engagement? They can be great leaders of change and propagators of change. Your thoughts, Sophia?
Hello, Dion, and hello, everyone. Yes, absolutely. I think that such a knowledge would definitely support young surgeons to develop specific skills and develop something to strive for. I cordially believe that such an engagement would measure the trainees' enthusiasm, motivation, and involvement with on-the-job participation and learning. I mean, undoubtedly, the more engaged the trainees are, the more effective the project will run, also the project in May. So I think that improving training engagement should be a top priority for us, since it can drastically impact the study's competencies and enhance the project's growth culture.
So, Sophia, I'm going to ask you online now, and this is being recorded, so be careful what you say. I'm going to ask you, can we contact all the young ESCP members and see if they can help engage in the training platform and engage their wider teams? Can we work together to do that?
Of course we can. We would publicize this to all of the young ESCP members through the ESCP website, through webinars, through the social media, through podcasts. And such collaboration on training and growing together is a turning point, evolving from the old way of thinking, going to the new way of thinking through trainees.
Fantastic. Sophia, I really look forward to doing that.
Me too.
So last but not least, I'm going to come to Nicolas in Argentina, although he is a bit of a globetrotter, so he's not always in Argentina these days, but I think he's in Argentina today. Nicolas, welcome. And you led an international collaboration across South America. That's really challenging. Can you help us engage a wider community in EAGLE-2 and to undertake the training across their hospitals across South America? How can we do this?
Well, actually, I didn't lead it. It's Juan here, and everyone here in Latin America led the process. So for us, EAGLE was like a start. It actually got us together. We got a network together thanks to EAGLE. And then after EAGLE, a lot of studies came up from Latin America. So actually we had it in us, and then EAGLE just helped us to get together. So now we have the network going. There's a lot of projects going on in IBD, cancer, proctology, everything here in Latin America. So now it's easier for us to get together. I think we will definitely get engagement for EAGLE-2. People will be very eager to participate, since they are very happy to be included in this type of studies. So just name it. You have EAGLE, you have any project, just name it. We'll engage and we will participate.
I think there's a very important lesson that you've shared there, Nicolas, and that is that you use the EAGLE trial to build teamwork and to bring the network together. So actually, it's a mutually beneficial process. So we hope we could use EAGLE-2 to do the same, to rejuvenate that collective feeling and that collective voice. I'd like to thank the panel, and I'm just going to close with a few words about EAGLE-2. Anyone can access the training platform from today. It is open and available for free to use for any surgeons, anaesthetists, trainee doctors. The key to it will be that you encourage teams to participate. So we don't want just individuals in hospitals, although they are welcome. Really, we want you to use EAGLE to build teams. This link will link you to a site to register your interest in participating in EAGLE-2. EAGLE-2 will look at outcomes from patients undergoing right-sided bowel resection and primary anastomosis in May 2024. So we have 4 months for teams to undertake the training and to undertake the education platform to build the teamwork in their hospital, so we can maximize the impact of this intervention and measure it, publishing it in the British Journal of Surgery before the end of next year. We need to start producing rapid change in practice, rapid improvement in outcomes for our patients. This is all about surgeons working together, building networks, building teams to benefit their patients. I want to thank all the panelists, all the speakers, and most importantly, all of the participants in the EAGLE collaboration. On that note, I'll sign out and we'll look forward to speaking to you again in the near future. Thank you very much.